He's a silent detective. And this silent detective is at work in every corner of the world, every corner of the globe. And this detective doesn't go about wearing the trench coat that most detectives do or carrying up the magnifying glass, detectives may carry. But he's responsible for solving some of the biggest mysteries of human health, from why COVID-19 swept the globe to why malaria stubbornly clings to some regions of the world, to even why your city might suddenly face an outbreak of cholera tomorrow. But here's the twist. This detective is not a person. It's science. And this science is called epidemiology. So today I'll introduce you to the science of epidemiology and how it works hand in hand with another health giant, a life-saving giant called community health. And together, they're responsible for some of the very important health measures that we take today to ensure the maximum health of you, your surroundings, and virtually everyone across the globe. So whether you're a doctor like myself or you're a farmer in southeastern or in India, for instance, or you're a grandmother in South America, wherever you are, this is your science. It's your science. And it's your science because it's about you, it's about your family, it's about your community, it's about the world at large. So by the end of this lecture, you'll be able to look at news headlines and statistics, or even the cough of a stranger in the bus, and you'll see the hidden story that most people will completely miss. So let's talk about epidemiology and community health. Talk about an introduction to epidemiology and community health. Now, let's take this circle I've drawn to be population. And suppose these stick men are human beings. Epidemiology comes from words that have Greek roots. Epi, meaning upon. Damos, meaning people. And logos, meaning study. So we have epi, and this is upon. We have damos for people, and logos for study. Thus, epidemiology, simply put, is the study upon people. Study upon people, that's epidemiology. But let's leave this fancy definition. Anyway, this is the origin of the word epidemiology. The World Health Organization, however, defines epidemiology as the study of the distribution and deterrence of health-related states or events in specified population and the application of that study to control health problems. I'm going to break this bit by bit so you have an understanding of what is really embodied by the World Health Organization's definition of epidemiology. So, we mentioned some words, and we'll try to explain what those words are. We said distribution. Said epidemiology is the study of the distribution, determinants, of health-related events, health-related states or events, health-related states, or events. As we mentioned, that being in a specified population. Specified population. And the application of this study to solve health problems. So we have application. Application to solve health problems. So these are keywords. These are the keywords that can be found in the WHO definition of epidemiology. Now, what do they mean? What do they mean? Distribution is simply talking about the who, the where, and the when. So, who gets sick, where those people are that get sick, and when. So, suppose this is Earth. Let's use the blue pen, Earth, and we have planets. Just anyhow it is. Just take my planet as it is. This are Europe and Asia, and somewhere here is Oceania and Australia. With Australia, then we have take this to be America and South America. So what that means, what is meant by distribution is, suppose we have some sickness. We notice that some people in Africa, for instance, have a particular kind of sickness, and we look at the age group, or just try to look at the distribution of where that sickness is for a particular type. Or we notice maybe in Europe there's a particular type of sickness that is predominant in Europe, or even in Africa, in Asia, or in the Americas, like North America, for instance, a particular type of disease that's there. So basically, distribution also talks about who gets sick, where the person is, and when. Now, determinants, on the other hand, the second word in the definition of WHO, refers to the why, and the why talks about the causes, the risk factors, and even the protective factors for that particular health-related state. Now, by health-related state or events, we're not just talking about disease. So, in the definition, we're not only studying diseases. We're studying even things like, for instance, we're studying injuries, we're studying disabilities, we're studying people's behaviors that influence health, behaviors like, for instance, smoking, some people smoke, or even the positive states like the wellness and the practices people do, exercise, for instance. So that is what is meant by health-related state. And of course, in a specified population, epidemiology is not clinical medicine. It's the medicine of a group of people, and of like a family. So this shows that the study could either be, say, in a school or a village, or even an entire country. So that's what is meant by the specified population. And lastly, the application shows that epidemiology is not just theory. It's not just theory done for theory's sake. It's meant, the knowledge that is gotten from the study of epidemiology is applied for the betterment of the health of the individuals there and to control health problems. Now, on the other hand, community health is sort of like the brother of epidemiology. And this community health is the arm that moves, from study to action. It's all about the protection and improvement of the health of a group of people through prevention, through education, through policy making, and organized community effort. So in community health, we have something like this. Let's take this to be community health. Then we have so in community health, we have prevention, and let's take this to be education, just education, and we have services. So this is community health. So, but there's a relationship between epidemiology and community health, by the way. And think of epidemiology as the detective who finds out what's going on. Then community health is the fighter or the firefighter, for instance, or the engineer or the city planner that are all in one. And they use the intelligence that is gotten from epidemiology, for instance, to stop outbreaks, to promote wellness, and to prevent the next crisis. So epidemiology, let's take epidemiology to be like a detective. Let's take this epidemiology. Assuming this is the detective's cap, this is epid. All of this, epid. Whereas com health entails all that is done to maintain adequate health. The measures that are taken to maintain adequate health. So that's epidemiology and com health. So the scope of epidemiology and community health is wide. And epidemiology, for instance, can be descriptive epidemiology, which focuses on what's happening, where that's happening, and who is affected. And so, let me give you, when you see something like this, like when you see a bar chart, for instance, that relates, suppose you have a bar chart, and this bar chart relates maybe age, let's say age group, to let's say number of people affected by a sickness. And so say you just have different levels. Now we have, say, age. It's a range anyway. Let's say the range of, this is just a bar chart anyway, so we'll just have this as, say, 5 to 10. And then here is 15 to 20. And here is 25 to 30. So this is more of this is just a sketch of a descriptive epidemiology. Analytic epidemiology now is talking about why that is happening. Why are those people having those illnesses? And what are the causes or the risk factors? So we try to find an overlap between the risk factors of diseases and their causes. Then for applied or field epidemiology is how we solve it in real time. It's how the diseases are faced head on in real time. So suppose this is a van, and we have this. Just take my van to be the way it is. This is my van. And what are the tires? Okay, the tires are usually here, right? So we have a tire here and we have another tire here. And this van is sort of like a mobile lab. So inside this place is a lab, on its way to a community. So applied or field epidemiology basically has to do with everything that's done to the application of the knowledge that's gotten from epidemiology and community health, and taking that knowledge to where it's needed to solve problems in real time. Now, this is the scope of epidemiology. The scope of community health, on the other hand, is equally as vast as that of epidemiology. And it spans things like health promotion, e.g. exercise campaigns, and anti-smoking drives, or disease prevention, like immunization, as well as sanitation. In addition to the disease drive, even health protection, such as safe water, for instance, and occupational safety. And even rehabilitation, like community physio programs, or policies and advocacy. For instance, when government enacts laws that control things like tobacco, for example, tobacco control laws. This is the scope of community health. And on a global scale, you see, the World Health Organization coordinates disease surveillance, and it also coordinates outbreak response, as well as health promotion. While regionally, we have bodies that oversee some of this. For instance, if you think of Africa, there's the African CDC, or you have the European CDC in Europe, or even the Pan-American Health Organization in the Americas. Locally, like in your town, for instance, you may have a public health department that applies the same principle that is being applied by the World Health Organization and all these other bodies on your streets. So don't forget, the scope of community health encompasses, promotion, health protection, disease prevention, rehabilitation, and policy. So that's the scope of epidemiology and com health. So where did epidemiology come from? Epidemiology science has ancestors. Where did it start from? Did it start from COVID-19 period, or did it start after the Spanish flu, or ancient times? When there was when they had plagues. So, of course, to really understand science, you must meet its ancestors. And epidemiology and community health didn't just appear one day. They evolved centuries after centuries, responding to, the more we responded to plagues, and we had discoveries, and went through all those various occurrences that happened over the years, including wars. That's what led to where we are today in epidemiology and community health. So in ancient time, that was just around 400 BC. Of course, we know of the father of medicine, Hippocrates, around that time. While in the city of the Greek island of Kos, he started thinking about why people fell sick. And then he noticed something fascinating. He noticed that people living close to meshes tend to have fever. Then he started connecting this illness with environmental factors. And he started connecting it with seasons. And he eventually connected it with people's lifestyle. And that eventually led to the moving away of the thought that medicine was caused by some angry gods and evil spirits, to actually having recorded idea that health problems have natural causes, which we can study. So Hippocrates, the father of medicine, that's why we even call it the father of medicine, a great man indeed. Hippocrates started thinking and making observations, and he thought of air, thought of things like water, thought of how all these things affected people's health, including where people stayed, the place. And this was the kind of like the birth of, or the seed, where the seed was planted, of the ideas of epidemiology. And in the Middle Ages, we know of the Middle Ages, where there was basically darkness and light in that period. First of all, around the medieval time of Europe, that's the medieval Europe, there was the Black Death that happened, and they called this Black Death the bubonic plague. And this Black Death swept across the continent for centuries, just around the 14th century. And it was estimated about 75 to 200 million people were killed by this Black Death. So while there was panic and superstitions, people had various, people were scared, of course. I mean, why were people dying from sicknesses? Some people even blamed comments, some people blamed different things. Some people started persecuting a group there was no knowledge, so people persecuted certain groups of people. Then some cities began to take some public health measures. And eventually, we started having things like quarantines and pest control and even burial regulations. Even Venice, a city in France, eventually established the world's first official quarantine station. That was in the around the 15th century, around 1423, thereabouts. So we had a shift from the ancient time, to where now we had cities placing quarantines and they had, of course, ways of also marking ships that had issues were affected, and there were kind of like areas where people were placed with certain sicknesses, and so people were quarantined. People that were infected with certain diseases were quarantined, and this, of course, kind of pushed further the kind of advanced epidemiology, the knowledge we use today in epidemiology and in community health. Then, in the 17th to 18th century, numbers started to take over. And so we came to the age of enlightenment. And there was a man known as John Grant, who was a fabric seller in London. We call them the haberdashers. And this man eventually started examining weekly bills of mortality. He wasn't a doctor actually, but he became the first person to apply statistical analysis to public health. He started noticing and noting the patterns in deaths and in births and the causes of death. Basically started keeping statistics of what was happening then. And this was where epidemiology started kind of like wearing a suit, because they started having things like numbers and charts and early population studies. Then in the 19th century, modern epidemiology as we know it today was born. And here, the story of this man that every epidemiology student loves, Dr. John Snow in London, popped up. So in London, in the 19th century, mid-19th century, thereabouts, around 1854, Dr. John Snow in London eventually observed, there was a cholera outbreak in London then. And so, people had theories then that they blamed a lot of things. Some people blamed miasma, said bad air. Some people suspected different things. But John Snow eventually suspected the contaminated water around. So he started mapping cases, and pinpointing, places. And then it now led him to a pump. There was a Broad Street pump. Then what he did was he eventually started removing the pump handle. And then he noticed that the cases of the spread and the infection, of course, eventually plummeted, it dropped. And this was epidemiology in action. Because he used observation, he used data, he used hypothesis, and he actually applied that knowledge to intervene on what was happening there. And so we moved from the era, the ancient times, to actual scientific application of knowledge and observation to solve health problems. While epidemiology focused on finding cases, community health, on the other hand, evolved through sanitation movements. So we had vaccination campaigns and health reforms in urban areas. For instance, in Britain, Edwin Chadwick eventually pushed for sewage system to reduce disease. And in USA too, another man known as Lemuel Sartuk, just around the time that John Snow went about his investigation of the cholera outbreak, the man in the US gave reports that led to the blueprints that were used for public health infrastructure in the US. Then, in the 20th century, we moved from genes, from germs to genes. The 20th century exploded with discoveries. The germ theory of disease, confirmed by Pasteur and Koch, were there. And even vaccines, for instance, for polio and measles and antibiotics like penicillin, all came around, were involved, were discovered, invented sort of in the 20th century. So epidemiology expanded from being an infectious disease to chronic. Not just people didn't just look at infectious diseases then. Expanded even to chronic illnesses like cancer and heart disease. Even occupational hazards and mental health and traffic accidents. Then in the 21st century that we are in, we don't just talk about global surveillance now. We have gone far, and we talk about things like you hear of genomic epidemiology and AI-driven outbreak predictions. If you think of COVID-19 dashboards, for instance, those were being updated in real time. Think of Ebola containment, for instance, to think of that of SARS, that's systemic acute respiratory syndrome, and MERS, even Zika. If you look at all of these things, in fact, don't talk about just the infectious diseases. Things like climate change now are things we are considering. We talk of antibiotic resistance, we talk of urban crowding. These are the new frontiers that are currently available in our own generation. And now, fun fact, you see, epidemiology is one of the few sciences that every single country on earth uses and shares, regardless of politics. Because outbreaks don't care about borders. Anyway, now that we've traveled from Hippocrates to the age of AI, which we are in, I think the next step should be to actually let's open this toolbox of epidemiology and community health. And let's look at the key concepts, the core concepts that guide every study, every outbreak, every investigation, and even every health policy. So in the next section, we'll talk about, in a clear way, try to understand the concepts in epidemiology and community health. We've defined the science, we've walked through the history. Now let's open a toolbox, because there are key concepts that every epidemiologist, community health worker, and even an informed citizen like you should understand, and think of them as the DNA of the field. So, one of the key concepts to take note of in epidemiology and com health is that of population focus. Now, there's a difference, or rather, we'll compare the clinical medicine and community medicine. So, in clinical medicine, the focus is usually on a single person. In epidemiology and community health, you're focusing on a group of people. So, one of the concepts that is very important to take note of is this population focus. We have a population focus in epidemiology and community health. We're talking about a group of people, and we're trying to figure out how many of them are affected, who is affected among them, where are they, these people that are affected, and why are they affected? In fact, why now? Why is it now that those people are affected? The next concept you have to take note of is the concept of distribution. So all we do is we look out for patterns. We ask ourselves, are there patterns in this disease? And we look out for these patterns in terms of TPP, in terms of time, in terms of place, in terms of person. And in time, we are trying to see, is this disease, is this seasonal? Is there a time it occurs? Or is it sudden? Did it just come? And we try to also look at the place. Is it more in urban areas? Is it more in rural areas? Or we try to compare countries and countries. So we look at the place as well. Try to look at the distribution in that place. Then we look at the distribution in person. And there we are looking at the age group. We're looking at the sex. Is it more in women than men? look at the occupation, look at the lifestyle, where it is more prevalent. So this is actually descriptive epidemiology, because we are looking at the what, we are looking at the where, we are looking at the who, we are looking at the when. Then another concept which was mentioned in the definition from the WHO is the determinants. And these are the causes and the risk factors, the why. And these causes could be either biological causes like bacteria or viruses or genetics. It could be behavioral causes like smoking or maybe the person's diet, what the person eats, or even the person's physical activity. Of course, it may have a positive or negative effect. So physical activity, for instance, like exercise, usually tend to have positive effect on health. So we are looking at the various causes and determinants. We're also looking at the environmental factors, like maybe pollution or housing or water supply. We also try to look at the social factors, maybe the education or the income of the person. Poverty is definitely one of the leading causes of sicknesses and diseases in the world. So we look at the social factors as well, and try to understand people's practices, like their cultural practices. And it's important to know of what we call the classic epidemiological triad. So we are looking at the agent, we're looking at the host, and we're looking at the environment. This is the epidemiological triad. Epidemiological triad. And this is what we consider in the determinants. Look at the host, to look at the agent, to look at the environment, which serves as the medium through which, of course, the agent eventually gets into the host, causing disease. So this is important. We'll talk about this in subsequent lecture. And we also try to look at, in addition to the determinants, we look at the health-related states and events. So, like I said earlier, we don't only track diseases. We also track injuries. We think of things like road traffic accidents, for instance. We track those things. If you think of disabilities, we are tracking disabilities. Think of birth outcomes. Try to see if maybe there's an increase in the number of babies that are born with low birth weight. So we are looking at all these various health-related events and states, which may even be positive, for instance, like physical fitness level of people. Negative and positive, basically. Then, in addition to that, we also try to look at the study and control. And what we do is, epidemiology doesn't just stop at description, okay? It applies those findings to control and prevent problems. And this is where the two fields eventually merge. Because epidemiology finds the problem and community health eventually implements the solution on those problems. So what we have is epidemiology basically does epidemiology. Don't forget, epidemiology investigates, leading to knowledge. Then community health applies that knowledge. Community health applies the knowledge, and we have action. And that's how it works. Of course, the next thing that's important, the concept that you have to know, is the concept of prevention levels. There are different prevention levels. When I was taught back the days when I was in school, we taught the primary level of prevention, the secondary level of primordial level of prevention, the primary level of prevention, the secondary level of prevention, the tertiary level of prevention. As you go higher, there's the quaternary level of prevention. So what does that mean? Now, in the primordial level, it's just talking about the policies and how those policies are enacted to basically improve the lives of the populace, then in primary prevention, we are trying to stop disease before the disease even starts. And what we do in primary prevention is give health education. We try to immunize individuals. We are preventing that disease before it actually starts. Now, secondary prevention, on the other hand, we try to detect people that have that disease early. And so we do things like screening. When people are screened, we try to get people that already have the disease as early as we can before they begin to manifest deep, serious clinical symptoms and signs. Now, in the tertiary level of prevention, the tertiary prevention, we try to reduce the impact that those diseases or people that have morbidity try to reduce the impact of that on individuals. And we do things like rehabilitation and many other things. So this, of course, is the higher level, the quaternary level of prevention as well. And that is actually, it has to do with people like myself, the health workers, and we try to study how, our practices influence health within the health facility. Now, these are the levels of prevention. They're important to take note of this core concept in epidemiology and community health. Another concept to take note of is the concept of community participation. See, community health thrives when people themselves are involved. So from identifying problems to implementing solutions, people have to be involved in those various steps. Because without the community buying into the various steps and basically the activities to promote their health, the best health plans will fail. So always remember, people have to be involved. Then also remember that in community health, we're not looking at only one sector. Health is not just it's not just the work or the job of the Ministry of Health. It's collective. So it also it spans across various ministries and various departments, agriculture, education, housing, transport, what have you. All of them affect health outcomes. So for instance, when you have safe roads, those safe roads will reduce trauma cases. That's like accidents. And if you have school, and those schools eventually have feeding programs, that will improve nutrition. So you can see how transport is linked to health and education. Everything is intertwined basically. So you also need to know that one of the key concepts, in addition to the community kind of concept of epidemiology and community health, is that it is intersectoral. So there's collaboration between various sectors. Now that we've known about the key concepts or the core concepts in epidemiology and community health, let's try to understand what is even the aim. What are the aims and objectives of epidemiology and community health? Now, the aims of epidemiology include one, we use epidemiology to describe the health status of the populations. Example, we try to figure out how many cases are there in, say, England. What's the mortality rate from the heart, the disease of the heart in Japan? So basically what we do is we try to describe the health status of a group of people, a population. Another aim of epidemiology is to identify causes and risk factors. We are pinpointing why a problem occurs, whether it's a virus, sanitation, whether it's smoking, or a combination of these factors. Then we also use epidemiology to predict, disease trends, and we try to forecast how will the disease spread or how will it decline. Try to see whether it will increase, which one will increase, which one will go down, how it will move. Just try to predict disease trends. And then we also try to control and prevent disease by applying the knowledge to actually protect people. So these are the aims of epidemiology. The objectives of epidemiology, on the other hand, they're more specific. Think of them as a checklist. So what we do is we measure disease frequency. And we measure things like incidence, we measure things like prevalence. Then we study the natural disease, the natural history, something we call natural history of disease. And that just simply means what happens when a disease is left untreated. So we study the natural history of disease. Then we also identify determinants of health and disease. Then we evaluate interventions and try to see their effect or efficiency. For instance, we try to ask ourselves, did the vaccination program that we adopted for a particular disease work? So we use, these are some of the objectives of epidemiology. And of course, we use epidemiology to provide evidence for policy and planning. Yeah. So these are the aims and objectives of epidemiology. The aims of community health, on the other hand, are to promote health and well-being, to prevent disease and disability, to prolong life, to reduce health inequalities, and to improve the quality of life. Now, have a look at the aim of community health. What are the objectives then of community health? The objectives of community health are the actionable sides of community health. And what that includes are, we use community health to provide basic health services to all, try to educate communities on health matters, and we encourage healthy lifestyle. We also monitor, the community health indicators, and we try to kind of like mobilize resources and coordinate with other sectors to see how to get best health outcomes. Then we prepare for and respond to public health emergencies. So these are the aims and objectives of community health. In exams, you can remember the main aims with the mnemonics 3P, 2R. The first P is to prevent disease. The second P is to promote health. Next P is to prolong life. The first R is to reduce inequalities. And the last R is to restore health where possible. There are applications of this in real life. During the COVID-19 pandemic, for instance, the aim and objectives weren't just theory. See, epidemiologists tracked cases and studied the transmission. And community health workers and teams tried to deliver vaccines, and they educated the public, and also tried to set up isolation centers. So you see, both of them work together to control pandemics, and owing to their aims. And so these aims are not just nice words; they're actually important, and they are essential survival strategies. Now let's look at the methods or the measures of epidemiology. And these measures, by the way, these are very important places. These are places where examiners like to use to set their exams. But so even if you're not a student, these are employed in data analysis and statistics of health and health-related events and situations and outcomes. So what are these epidemiological measures? One, incidence. Incidence is one of them. And what is incidence? Incidence just simply tells us about the new diseases or new cases. So think of it as the speed at which new diseases appear in the population over a specified time. It is crucial for defining outcomes and measuring risks. Incidence rate is equal to the number of new cases in a period of time divided by the population at risk during that period, multiplied by a multiplier, e.g. 1,000. We tend to use 1,000 a lot. Let me give an example. Suppose a village, we have a village of 10,000 people, and in this village of 10,000 people, we have 50 new cases of malaria in 1 year. The incidence rate is take the number of new cases, which is 50 during this period, and we divide it by the population at risk, which is the population of the village, which is 10,000, and then we multiply it by the multiplier. And so that becomes, to measure the incidence rate, the number of new cases in this village, we have people that have number of cases. We have number of cases. Let's take this as the number of new cases. Number of new cases as 50. Then we said the population of the village. Population of the village is 10,000. So to measure incidence rate let's take incidence rate as IR, will be equal to the number of the new cases, which is 50, divided by the population at risk, which is 10,000 multiplied by the multiplier, or times the multiplier, which in our case we've agreed to use 1,000. And so, of course, that gives you 5. So we have 5 cases per 1,000 people. That's the incidence rate. 5 cases per 1,000 people. And so, say incidence, number of new cases. And the incidence rate now, measured using this formula, is 5 cases per 1,000 people per year, because it's in a defined or specified period of time. The next epidemiological measure to use or to know of is prevalence or prevalence. Prevalence tells us about all the cases, old and new, all of the cases present at a specific time. Always remember a specific time, because you can't just say the prevalence of disease is this. It can be 50 for now, but the next year may not be 50, maybe 100. And maybe prior to the 50, it was 5. So you need to make sure you tie it to a time, specific time. It's important. So the prevalence is the total number of cases, both the old and the new cases, present at a particular or specific time. And it's like, it gives us like kind of like a snapshot view, of how widespread the disease is. And quite similar to incidence, but different. Prevalence can be calculated. The rate of it can be calculated. And the prevalence rate is equal to the number of new cases at a time divided by the total population. The number, did I say new cases? Number of existing cases, new cases is incidence. The number of existing cases at a time divided by the total population, multiplied by the multiplier. And so if in that same village where we had 10,000 people, we now have 200 people currently have malaria, the prevalence eventually becomes, now this is the number of new cases. Let's use red for the number of all cases. The number of existing or all cases, existing cases, as, let's take this to be 200. So similar formula, but in this case, for incidence, we used the number of new cases. For this, we use incidence rate. We use number of new cases. For prevalence rate, we will use the number of existing cases. And so we have 200 as the total number of cases divided by the 10,000 population of the villagers or the people at risk, multiplied by the multiplier, times the multiplier. So of course, you have this becomes 20. So we have 20 cases, a prevalence rate of 20 cases per 1,000 people at that particular or specific time. That's how prevalence is. We've talked about prevalence, incidence, we talk about prevalence. In addition to the incidence and prevalence, we have mortality rate. And mortality rate measures the death frequency in the population. And it's often expressed as so deaths or the deaths per 1,000 or 100,000 per year. So mortality rate is equal to the number of deaths during the period divided by the population at risk, multiplied by the multiplier. And so in that one, we also, let's put this, suppose we have the number of deaths here, number of deaths to be whatever, equal to x, for instance, x being anything. Mortality rate, this one is for mortality rate, MR. Mortality rate is equal to the number of deaths in a specified time divided by the population, total population, or the population at risk, which is 10,000, multiplied by the multiplier. So that's how you get mortality rate. The formula is quite similar to that of incidence rate and prevalence. So in addition to mortality rate, we have something called the case fatality rate. And what is case fatality rate? This tells us how deadly disease is. It kind of gives like the proportion of people that are diagnosed with the disease and the proportion of those people that have been diagnosed with the disease that die from that disease. So for instance, when we have 10 people who are diagnosed of, say, or we have 100 people who are diagnosed of Ebola, for instance. And in these 100 people, we have 10 people out of the 100 who die. The case fatality rate of Ebola becomes the number of deaths from Ebola, which is 10, divided by the number of diagnosed cases, which is 100, times 100. It's usually expressed in percentage. Total time is 100%. That being case fatality rate. Tells us how likely kind of someone will die from disease in a given population at a particular time. So the case fatality rate will be equal to, I said, we have 100 people affected, so number of people affected as the denominator, and then out of the 100 people, we have 10 deaths. So here is the deaths per time, and then here is the number or the frequency of cases or affected people at that time, multiplied by 100. Here we don't use times 1,000 multiplier, it's a rate in percentages. So multiply by 100, and then this becomes because this basically becomes 10. So we have 10% for this case, hypothetical case that I've mentioned. So the case fatality rate in this example I've given is about 10% based on how we've calculated it. We have something called the attack rate. And attack rate is a special kind of incidence used during outbreaks. So it shows the proportion of people who become ill after exposure. So attack rate is equal to the number of new cases during outbreak divided by the population at risk times 100%. So remember what I said? I said attack rate is what? I said attack rate is the special kind of incidence which is used during outbreaks. And it shows the proportion of people who become ill after exposure. So what that means, we have to take the number of new cases during that outbreak. The number of new cases, attack rate becomes the number of new cases, during that outbreak divided by, oh no, this will not work because I need to put that times 100 there. So let's start from here. Attack rate is equal to number of new cases divided by the population at risk multiplied by 100%, giving us an idea of the number of people that get the disease during an outbreak. Another epidemiological measure is what we call the risk ratio. The risk ratio or the relative risk. And what is relative risk or risk ratio? This compares the risk of disease in an exposed group of people versus an unexposed group of people. So risk ratio is equal to incidence in exposed divided by incidence in unexposed. We are comparing the risks of disease in an exposed group of people versus in a non-exposed group of people. A certain group of people are exposed to a disease. Another certain group of people are unexposed to disease. So we are comparing their ratio. And so this becomes the ratio or incidence in exposed divided by the incidence in unexposed. And if the risk ratio is 1, then there's no difference. If the risk ratio is greater than 1, that implies that the incidence in the exposed is higher than the incidence in those people that are unexposed. Then the exposure to that factor eventually increases risks. If the risk ratio is less than 1, the exposure to that factor is protective. Let's put this out so you understand better what I'm saying. So we said risk ratio is just a ratio. Relative risk or risk ratio is just a ratio of incidence in exposed group. Exposed group. Incidence in exposed group divided by incidence in unexposed group. Unexposed group. That's the formula. Now, it's a ratio. So suppose we have 2 sets of people. Let's put it this way. Let's put 3 people each. A group of 3. I don't want to draw so many people. So we have 2 people. And in this first group of people, we expose them to something. I'm spending time here because I want you to understand what I mean. Now, we expose them to a factor. And having exposed them to the factor, we have 2 people being affected. Whereas the unexposed, the incidence in them is just maybe 1. Let me use a different color. We didn't expose them to anything. Let me use green to mark people that were affected. So we have incidence here. Incidence. These are the incidence. I haven't exposed them to a factor. These are the people that are affected. Then we didn't expose this other group to any factor, but we have 1 person. The incidence of that stuff in 1 person. So what happens? What is the ratio? This is the exposed group. So the exposed group becomes 2, and that the incidence in the exposed group is 2. The incidence in the unexposed group is 1. So we have a risk ratio of 2. Now, I'll mention something. I say when the risk ratio is higher than 1, we have risk ratio may either be equal to 1 or risk ratio may be greater than 1 or risk ratio may be less than 1. So when the risk ratio is equal to 1, there's no difference. So whether you expose people to the factor or not, they will get affected at the same way. There's no difference. The factor does not play a role in determining who is affected or not in both groups. Then when you have the risk ratio greater than 1, it means the factor, the exposure, is a risk. Because we expose them, you can see this, my answer here was 2, so we expose them to this factor, and we had 2 people being affected. Whereas the people that were unexposed were 1. So greater than 1 shows that the factor that the people are exposed to plays a role, it's a risk. And less than 1, so supposing this was the other way around, and we had it this way, such that this was the factor was applied here, and instead of having one person was affected here, meanwhile for the unexposed, we have 2 people. It shows that applying this factor reduces the risk of, let's say, incidents. Reduces the amount of incidents or the risk of infection. I don't use infection because it's not just disease. So, but it influences the incidence in the exposed group. And that shows that the exposure in that case is protective. And that's risk factor. Now, in addition to risk factor, there's the risk ratio, there's the odd ratio. And what is the odd ratio? The odd ratio is used mainly in case control studies. And what it does is that it estimates how more likely cases were exposed compared to controls. So, odd ratio is equal to the odds of exposure in cases divided by the odds of exposure in controls. But we use it, like I said, in case control studies. Odds of exposure in cases divided by the odds of exposure in controls. Remember, incidence and prevalence aren't interchangeable. By the way, one way to remember or understand incidence and prevalence is to know that incidence has to do with inception, incidence and inception, whereas prevalence has to do with the presence of something. So incidence to inception, prevalence to presence. And so they are not interchangeable. Now, incidence is great for studying causes and risk factors, whereas the prevalence, I don't know, I keep twisting my tongue. The prevalence is useful for planning trends and planning activities and health initiatives and programs. So these are the epidemiological measures you should take note of. We've gotten these numbers, but how do we collect these numbers? And that's what we're talking about, the epidemiological study designs. Because, yeah, we're talking about how to calculate this, calculate that. We're using numbers up and down, but you have to get the numbers first. So how are the numbers collected? Where do we get, what process, what steps do we use to get these numbers? Epidemiological study designs. So, see, numbers are only as good as the way you collect them, okay? And the study designs is like the blueprint. It's the blueprint. It's not just like, it's the blueprint actually for how epidemiologists actually investigate health problems. So today, I have to introduce you to the main types of study designs so that you know what they are good for and you know how to use them, because this knowledge is essential to anyone working or studying public health. So what are these study designs? These are various designs or blueprints we adopt to study population or a health. Remember in our definition we talked about using epidemiology is trying to study distribution determinants in a specified population. We're trying to actually study the health-related events and states in a specified population. So what are the ways we study those health-related events or states in those specified population? So epidemiological study designs. One of it, we actually group them anyway into two. We have the descriptive studies and the analytical studies. So one study describes what's going on. Then we have another set of studies that analyzes. It doesn't just describe. It goes a step further to analyze. So the descriptive studies, epidemiological study designs, we have the descriptive studies, the analytical studies, observational studies, and experimental studies. We'll explain all of that. So for the descriptive studies, what they do is they tell us who, they tell us what, they tell us when and where. Those are descriptive studies. And what are examples of descriptive studies? We have, when you hear of a case report, or a case series. A case report, just one. A case series is a group of case reports, likely linked to themselves. They give details, or like a story, of either one or more patients with a health condition or a disease. Then we have, under these descriptive studies, I mentioned two already. I mentioned the case report, I mentioned the case series, under descriptive studies. In addition to the case report and the case studies, and the case report and the case series, we have what we call the cross-sectional studies. And these are more or less referred to as the prevalence studies, because they look out for the health status in the population at one point in time. For example, if you do a survey, for instance, you're trying to measure obesity rate in the city today. That's a cross-sectional, just like it gives you a cross-sectional picture of what's up with obesity in that city at that point in time. So these look at the health status in the population at one point in time. Then, having talked about the descriptive studies, which is a type of epidemiological studies, we then look at the analytical studies, two main types. Now, of course, I didn't want to add that this. In addition to this, we have, I'll talk about that lastly, we have ecological studies. So we have three: descriptive studies, analytical studies, ecological studies. So I haven't talked about descriptive studies. The analytical studies, we have the observational studies and the experimental studies. For the observational studies, what we do, by the way, the whole analytical studies, as it says, is where we dig into why and how, and try to understand what's going on. Why is it going on, and how is it going on? And this is a place where we eventually test hypotheses about cause and effects. Try to reach conclusions through our hypotheses, and there are numerous tests we run. Those hypotheses we have for why and how, try to test them and see the outcomes we get. I haven't tested those hypotheses. And so the analytical studies may either be observational studies or experimental studies. The observational studies, we don't intervene. Researchers just observe. We don't intervene. And in observational studies, some examples of types of observational studies include the cohort studies and the case control studies. So what are cohort studies? Cohort studies are actually like when we follow a group over time. We just follow them over time to see who develops disease based on an exposure. For example, when we follow a group of smokers versus non-smokers, we have smokers and we have non-smokers, and we follow them over time, and we see who develops lung cancer eventually. That's the cohort study. It has its pros, it has its cons. The pros, of course, that helps us to can measure in that way, because we are checking the smokers and the non-smokers over time. We can see the incidence, and we can also look at and know the risks. But the problem is, the cons, which are the problem, is that it's time consuming and it's expensive because you have to follow them over time. So it's a type of observational studies. Remember, I said observational studies, we just observe. Researchers, we don't really intervene. And the type of observational study I've talked about now is the cohort studies, where we just follow a group of people over time and see who develops the disease based on our exposure. Another type of observational studies we have is what we call the case control studies. And the case control studies we start with people who already have the disease, or the cases. And then we compare their past exposures to those without this disease, which becomes the control. For example, when we examine what exposures caused a recent outbreak, we are using case control studies. Let me repeat myself. I said the cohort studies, we follow people over time. Take, for instance, smokers and the non-smokers, and we look at who eventually develops lung cancer, supposing we are comparing their smoking to development of lung cancer. Then for the case control studies, I say we start with people who already have the disease or the cases. So we look at people maybe that already have lung cancer. Then we compare their past exposures to those without the disease. So we look at people that have maybe what they expose themselves to. Could be smoking, is it drinking, whatever the exposures they had. We compare those that don't have the disease and see how, just compare and see. Of course, we're just observing. I said observational studies, we just observe. And we try to deduce the relevant information we need from these studies. The advantage of the case control studies, it's quick because it's good for rare disease. However, it has a cone of one of the challenges. It has I think it has recall bias. Yeah, it has recall bias. Recall bias is possible. So these are types of observational studies under the analytical studies. Then we have what we call experimental studies. Experimental. They're not observing now, we're experimenting. So somehow we have interventions. And so here, the researcher actually actively assigns exposure. The gold standard for experimental studies, just remember when I was in medical school, my lecturer used to like this a lot. She loved this. So the gold standard for experimental studies is the randomized clinical trials. The randomized control trials. We had the randomized control trials, the randomized control trials. So the randomized control trials are referred to as the RCTs, and also have the non-randomized control trials. So in this case, participants are randomly assigned, to receive interventions or placebo. You take a group of people, you give them placebo. By the way, just a drug may not have any physiological effect in them, but when given to the patient has known something is happening. Meanwhile, not is happening. So we give them those interventions or the placebo, depending on what kind of study you are doing or is being done. And then this, by the way, helps us to prove causality. Of course, it's widely used in vaccine and drug testing. Of course, I mentioned, let's not forget, my ecological studies. In addition to the observational, the descriptive studies, and the analytical studies, we have the ecological studies. And ecological studies look, this looks or groups population. It kind of looks at individuals or groups as population. It doesn't look at, we are not looking at studies as individuals. We group them together as a population. And we try to compare disease rates with the exposure between countries and regions and time periods. So ecologically, in groups of people. And then we compare them, compare the rates of exposure. The exposure with the rates. So these are the various ecological study designs we employ. You see, in COVID-19, during the COVID-19 pandemic, for instance, descriptive studies, case reports, case series. Descriptive studies were what we used to get the number of new cases per day. Descriptive studies. Then the analytical studies, for instance, the observational studies were how we were able to eventually know what were the risk factors and what were causing those things. Of course, clinical trials were run, and that was how we eventually figured out what vaccines to use and basically the treatment modality of that COVID-19 pandemic period. So you see how we apply some of this practically. You know what epidemiology is and how it developed. You know its concepts, you know its studies designs. Now let's look at how the science is used, from saving lives in outbreaks to shaping global health and global health policies. Epidemiology is actually the engine driving public health. So how do we apply knowledge? Our definition of epidemiology, remember we talked about everything leading to application to solve or prevent diseases and health states or events based on the knowledge we've gotten from the study of the distribution and the determinants. So we have to now look at how we apply that knowledge. Really. How do we apply that knowledge? We apply that knowledge by disease surveillance and outbreak investigation. Epidemiology keeps constant watch on diseases. It's a watch that's kept on diseases. So we have surveillance systems that detect unusual patterns and kind of trigger investigations. So it's like a radar. Let's imagine a radar, And the radar has sort of like a magnifying glass on the world, looking at areas to fish out where there's challenges. And what we do there with disease surveillance and investigation, outbreak investigation, is we try to identify outbreak quickly, so that we prevent the spread. Then, for example, COVID-19, Ebola, cholera. That's what we do. Field epidemiologists actually go to the ground, they try to collect data, and they trace contacts, and they trace contacts, and they recommend control measures. So, surveillance, disease surveillance, and outbreak investigation. Another way we apply this knowledge of epidemiology is by risk factor identification. So what we do is we study population. By studying population, we eventually find what causes of disease. For instance, we talk about smoking and lung cancer. We can also talk about how cancer can be, or smoking rather, or lung cancer can be affected by obesity and diabetes or unsafe water and cholera. We just try to link all these things together and find what causes what. So we try to figure out what the risk factors are to certain diseases. The knowledge guides our prevention programs, and we also try to evaluate interventions and programs. Like epidemiologists, for instance, epidemiologists use epidemiology to tell us if vaccines or the screenings we are doing or the health education or whatever campaign we are doing, it tells us if those campaigns we are employing are actually working or not. So we try to evaluate. So evaluation of interventions and programs is another way we apply epidemiology. Another application of epidemiology is in health policy and planning. Health policy and planning. You see, government rely on this epidemiological data we collect to allocate resources and to design health policies. So that's another application for health policy and planning. Of course, another application in addition to the health policy and planning is health promotion and disease prevention, because epidemiology actually informs what health behaviors to promote and which risks to reduce. So try to encourage people through adverts to adopt certain lifestyles and to dissociate from non-healthy lifestyles. By so doing, we are doing health promotion and trying to prevent diseases. They always say smokers are liable to die young. That's a form of disease prevention. So occupational and environmental health is another way we apply this knowledge, because by monitoring workplace hazards and environmental exposures, we are able to protect workers and we're also able to protect communities. Yeah, we also use what do you call it? We use another way we apply the knowledge is emergency preparedness and response, where we plan for natural disasters and we plan for pandemics and plan for bioterrorism. All of these rely on epidemiological insights. Even research and innovation, important. I always remember my supervisor. During my final year, we did research with him. And so, of course, we do another way epidemiologists employ this through research and innovations. And so epidemiologists actually contribute to medical research, try to discover new disease patterns, they try to understand genetic links to situations, and the effect of lifestyle changes. So these are the various ways we apply the knowledge gotten from epidemiology and community health. So next, we look at the principles of community health practice. Principles of community health practice. We've seen how epidemiology uncovers health problems. Okay. Now let's see how communities use that knowledge. The principles of community health practice are actually the backbone of effective public health action. So we'll explore this one by one. Number one, community participation. The community must be involved at every stage, from identifying problems to designing to implementation. Every single stage, community must be involved. Why? Because people own what they help to create. For example, if you have a program on malaria, a malaria control program, it will only work best when the local leaders and the residents are involved and they are engaged. So community participation is one of the important principles we adopt in community health practice. Which other principle do we employ? Another principle we employ is empowerment. And what is empowerment? Empowerment means giving people the knowledge, the skills, and the confidence to make healthy choices. You give them the knowledge, the skills, and the confidence. You don't just give them the knowledge. It's not enough to know. You give them the knowledge, the skills, the confidence. So you're not just telling them what to do. You are enabling them to be able to do that. That's empowerment. Then equity and social justice is another principle of community health. So health services and interventions must be fair, they must be accessible to all, especially the vulnerable and the marginalized. So equity and social justice is another principle of community health practice. Also, there has to be inter-sectoral collaboration. What does that mean? Remember, we talked about how you need to integrate different sectors of a nation or of an economy. Health, agriculture, transport, education, what have you. So there has to be intersectoral collaboration. No single sector can achieve health, can achieve maximum health alone. So education, housing, agriculture, transport, finance, they all influence health outcomes. Of course, you need to talk about sustainability and that's another principle, because health programs should be designed in a way that they last. You can't do something today and just expect it. Just do today and then you're out. Come on. It has to last. So sustainability is one of the principles we keep to. by using local resources, for instance, and the capacities, rather than just doing short-term, short-term fixes. You just come and dump something, bam! After 1 month, it's really bad. It's not working. That's wrong. That's not a principle. We use principles, so it has to last long. Sustainability is important. It's a key principle to how we practice community health. Also, we also try to make it holistic. So, holistic approach. And community health considers don't just consider the physical person. We consider everything. We consider the physical, we consider the mental, we consider the social, we consider the environmental factors all together. So it has to be holistic approach. Then we do evidence-based practice. we are not soothsayers. We don't just sit here and imagine. We are not like those in the ancient times where they thought angry gods or comments were the cause of their problem. We use evidence. It has to be evidence-based. So decisions should be guided by data, be guided by research, be guided by evaluation, not just tradition or opinion, what you think. Understand? So it has to be evidence-based practice. Of course, prevention has to be the focus. So prevention focus. By prioritizing prevention over treatment, we're going to save lives and resources. You don't have to always wait till something gets out of hand to want to treat. So prevention focus is another principle of community health practice. So what is the relationship between epidemiology and community health? You see, community health and epidemiology are actually two sides of the same coin, okay? And they partner in public health success. So let's unpack this powerful partnership because they partner together. 1, epidemiology provides the evidence. Epidemiology is science, okay? It discovers what diseases are present and how they spread, and who is at risk and why. It also provides data and insights that inform the community health actions. Community health, on the other hand, puts evidence into action. And so community health is the practice. It uses the epidemiological evidence to plan, to implement, to evaluate health programs, and it mobilizes communities and coordinates resources and delivers interventions. There's a continuous, in addition to these two, there's a continuous feedback loop. It's a loop. Community health programs will generate new data on outcomes and challenges, which epidemiology will now analyze to refine strategies, which is then used by the community health, which will then provide data, which basically continues like that. So it's a continuous feedback loop. And so this is how they interact. So in summary, summarize and conclude, talk about epidemiology, introduction to epidemiology and community health. Of course, by the way, don't forget that epidemiology gets its data and community health helps to implement those necessary interventions that are required for the health of the public. So we've journeyed through the fascinating world of epidemiology and community medicine, community health. Now let's quickly recap the key points in all that we've covered, to cement your understanding. So what is epidemiology and community health? Epidemiology, remember I said, is the science of studying disease pattern and causes in population, whereas community health is the practice of applying this knowledge to improve the health at the community level. These are the definitions. We also talked about the history, right? Yeah, we did. We talked about the history from the time of Hippocrates to modern day global surveillance. And we talked about epidemiology and how it has evolved as vital to public health. We talked about the core concepts. We explored population focus, distribution, we talked about the health events, we talked about prevention levels, we talked about the importance of community participation and equity. We mentioned all of those things. We mentioned the aims and objectives. We say the ultimate aim is to prevent disease, to promote health, to prolong life, prevent disease, promote health, prolong life, to reduce inequalities and to improve the quality of life. We also learned key measures like incidence and prevalence and mortality rates, and study designs from descriptive to experimental. The tools that are required for the trade of epidemiology and community health. Of course, remember the applications we mentioned, how epidemiology drives surveillance and outbreak controls, research drives policy making and community health practices. And even the community health practices rest on the population, the principles rather, that are gotten from epidemiology, such as participation, empowerment, equity, and sustainability. We also talked about how together they form a dynamic duo, and we mentioned how everything that is done in epidemiology and community health is evidence-based, and how this is done to protect the health and lives of population worldwide. So whether a student or a healthcare professional like myself, or you're simply just a curious mind, trying to understand these fundamentals that are crucial to shaping how we respond to pandemics and chronic diseases and emerging health challenges. This video, I'm hoping that this video is helpful for you. And by the way, here's an amazing fact. Do you know that the principles of epidemiology are increasingly being used beyond human health in areas like ecology, for instance, and economics, and even social sciences being used? And that leads me perfectly to the next exciting topic we'll be talking about, which is human ecology, where we'll try to explore the intricate relationship between humans and their environment and how this shape health and human life in general. So I'll see you in the next lecture on epidemiology and community health, which will be on human ecology. With that said, thanks for watching this video. Dr. Joshua Odo. If you like this video, please hit the like button, subscribe, and hit the notification bell so you can get notified whenever we share more lectures as this. And feel free to share this with your friends, your family, and as many as are going to be interested in things like this, of course. And yeah, I'll see you in the next video, okay? Yeah, take care.